Our today's topic is diabetes mellitus. As we all know, diabetes mellitus has become a global epidemic. If we just look at the few facts of 2019, we can see 79% of adults with diabetes were living in low socioeconomic and middle income countries, and 463 million people, adult people, were living in the world in 2019 with diabetes, and it will be 700 million by 2045. Diabetes caused 4.2 million deaths in last year, and it almost cost $760 billion just in last year. So we all can understand that how much important diabetes mellitus is in our day-to-day life. So we must understand it very properly, and we try to give some concentration for this. Diabetes is a chronic disease characterized by hyperglycemia that occurs either when the pancreas doesn't produce enough insulin or when the body can't effectively use the insulin it produces. If we say it in simpler form, then it is a disease characterized by hyperglycemia when there is absolute and relative deficiency of insulin. Either the body doesn't produce insulin or the body cannot use the insulin it produces, and the result is inevitable hyperglycemia. There are four types of diabetes. Type 1 diabetes, previously known as insulin dependent, which is characterized by the absolute deficiency of insulin, and it always requires insulin, daily insulin administration, to survive. Type 2 diabetes, which is the most common form of diabetes mellitus, and gradually the number of this type of diabetes is gradually increasing because of our bad lifestyle. Because of our lifestyle, we are gaining weight, excess weight. We do less physical activities, so it is causing insulin resistance, and as a result of that, we are developing type 2 diabetes. Gestational diabetes mellitus, or GDM, which we found during pregnancy. Women with gestational diabetes are always at risk of complications during pregnancy and after delivery, and they, as well as their children, are always at risk of developing type 2 diabetes in future. Diabetes due to other specific causes. There are many causes of diabetes apart from type 1, type 2 and GDM. It can be autosomal dominant genetic defect of pancreatic beta cell like maturity onset diabetes of young adult, MODY. It can be due to insulin ATP sensitive potassium channel defect. It can be neonatal diabetes. There are some exocrine conditions where diabetes can occur, like pancreatitis, neoplasia of pancreas, cystic fibrosis, hemochromatosis. Some endocrinopathies like acromegaly, Cushing syndrome, glucagonoma, pheochromocytoma, hypothyroidism. Some drug, those may cause diabetes, like pentamidine, VAC, or cyclosporine, alpha interferon, thiazide diuretics, beta blocker, alpha agonist, phenytoin. And glucocorticoid is a very common drug that causes hyperglycemia. Some infections like congenital rubella, cytomegalovirus, Coxsackie virus, adenovirus, these can cause hyperglycemia. There are some syndromes like Down syndrome, Turner syndrome, Wolfram syndrome, Klinefelter syndrome. In this syndrome, diabetes is one of the feature. So the clinical features. Many of us know the typical clinical features like increased thirst, urination, increased hunger, fatigue, blurred vision, numbness, and tingling of hands, uh, sores that uh, doesn't heal or delayed healing, unexplained weight loss, recurrent UTI, pruritus in vulva, recurrent unexplained abortion. So these are the common features uh, with which the patient may present. But we should always remember that we shouldn't expect that the patients will always present with typical features. Most of the patients of diabetes mellitus are diagnosed incidentally. Some patient may come for any surgery, they go for routine test, or if you do other tests, then you might find that the patient has hyperglycemia. So it's not always necessary that the patient will present with polyuria, polydipsia, polyphasia, but you should understand the reason behind this, the cause of polyuria, polydipsia, polyphasia. If you recall, you can remember that the function of insulin, it not only causes glucose influx into the cell, but it also prevents protein breakdown, fat breakdown. So if your body cannot produce insulin, or if your body cannot utilize the insulin, then there will be increased catabolic functions. As a result, your protein mass, fat store will be broken down, and your weight will be lost. Because of hyperglycemia, your body's osmolarity will be increased. So if your body's osmolarity is increased, then the body will try to compensate it. The body will compensate it by passing excess amount of glucose through urination. That means glycosuria. So body will pass excess glucose through urine. As a result, your urination will be increased, and because of your excess urination, the patient will be dehydrated. So if you are dehydrated, if the patient is dehydrated, then you will have increased thirst. So this explains the reason behind polyuria and polydipsia. Because the reason behind polyphasia is as your body mass is depleting, so there will be increased demand of food, nutrition, calorie of the body, and your satiety center will be inhibited, and you will have increased hunger. Blurring of vision may be a clinical feature with which the patient may present. It is due to increased viscosity of aqueous humor. This results due to increased osmolarity of the body. Happens due to increased glycosuria, and delayed healing is due to immune deficient condition. So how do we confirm whether the patient has diabetes or not? Definitely we will go through some test investigations. So the investigations are either you will go for OGTT or oral glucose tolerance test, which is the gold standard test. or you can advise fasting blood sugar, HbA1c, random blood sugar. But always remember that if it is feasible, if it is possible, you will always go for oral glucose tolerance test, because if there is any kind of doubt in fasting blood sugar, HbA1c, or random blood sugar, we'll again have to go through OGTT. And if OGTT report is normal and random blood sugar or HbA1c or fasting blood sugar report isn't normal in favor of diabetes mellitus, the physician always consider the report of oral glucose tolerance test. So whatever the result is, oral glucose tolerance test report is the final. And there are other factors which we should consider, like if the patient go for fasting blood sugar, the patient must be in fasting state for at least 8 hours. Regarding HbA1c, there are certain criteria, laboratory criteria, which should be fulfilled. Otherwise, HbA1c report should not be considered. And beside that, in some conditions where the RBC turnover is increased, if the patient has those conditions, then the HbA1c investigation is not encouraged. It can be pregnancy, it can be any hemoglobinopathies, and if the patient is of extreme age, that means below 18 years old or very old person, in that case HbA1c test is not encouraged to be done. Regarding random blood sugar, if the patient doesn't present with typical features of hyperglycemia along with increased random blood sugar, then it is always doubtful. Even the patient presents with typical features of hyperglycemia along with increased random blood sugar, that means above the range, even then there is some windows of doubt. So in gist, we should always go for oral glucose tolerance test, and if possible we should go for HbA1c to determine how our management should be. So whom should we advise for testing diabetes? Definitely those who are overweight and obese patient, they should always go for testing diabetes mellitus. If they has certain criteria, if they have certain risk factors like first degree relatives with diabetes, if they are belong to high risk ethnicity, all of these subcontinent people are in high risk ethnicity. So in that case, all Bengali people should go for OGTT or blood sugar test if we are obese and overweight. If someone has history of cardiovascular disease, if someone has hypertension, dyslipidemia, if any woman had or has polycystic ovarian syndrome, if anyone is physically inactive, and if someone has some features of insulin resistance like acanthosis nigricans, and all patients with pre-diabetic status, those who are already diagnosed as pre-diabetic, They should always go for diabetes checkup yearly. And women who were previously diagnosed with gestational diabetes mellitus, they should always go for blood sugar testing. Ideally, I should say that they should always go for OGTT at least 3 years interval. And the patients who are above 45 years old, they should also go for OGTT. And if the results are normal, testing can be repeated at the interval of 3 to 5 years. It depends the initial result and the risk factors the patient has. So, the criteria for diagnosis of type 1 diabetes mellitus, type 2 diabetes mellitus, or diabetes mellitus due to any other causes except gestational diabetes mellitus. So, we should always go for OGTT. Oral glucose tolerance test with 75 gram glucose. If fasting blood sugar is above 7 millimole, above or equal to 7 millimole per liter, and 2 hour after blood sugar is equal to or above 11.1 millimole per liter, if any of these criteria is met, a level is met or exceeded, then the patient has diabetes. If anyone's HbA1c is 6.5 or above 6.5%, then the patient has diabetes. As I have already mentioned previously that there are some considerations regarding HbA1c that should be always be considered, because otherwise HbA1c is not an ideal test. And importance of HbA1c is it is necessary to determine how we should initiate the management of the patients. There are some criteria which we will mention when we talk about the management of diabetic patients. Regarding random blood sugar, if random blood sugar is above or if the random blood sugar is 11.1 millimole per liter or above 11.5 millimole per liter, 11.1 millimole per liter, considering the patient has typical features of hyperglycemia or the patient is already in hyperglycemic crisis, then we can say that the patient has diabetes mellitus. Otherwise, we should always go for OGTT and definitely OGTT. And in absence of unequivocal hypoglycemia, unequivocal test result, we can consider repeating the investigations. So there is another stage of dysglycemia that is called pre-diabetic stage, impaired fasting glucose or IGT, impaired glucose tolerance. If the fasting blood sugar is in between 5.6 to 6.9, then it is considered as IFG, that means impaired fasting glucose. And if the postprandial sugar level after taking 75 gram glucose is in between 7.8 to 11, then it is also considered as pre-diabetic condition or IGT, impaired glucose tolerance. Regarding HbA1c, if the HbA1c is between 5.7 to 6.4, then it is called pre-diabetic stage. In diagnosis of GDM, we have only one option, that we should always go for OGTT, oral glucose tolerance test. HbA1c is not encouraged, which I have already mentioned, that where the hemoglobin turnover is increased, in that case HbA1c is not an ideal test, and pregnancy is one of the conditions. So in GDM we follow a different diagnostic criteria, and in OGTT 3 samples of blood are taken for diagnosing GDM. It is taken at fasting condition, and second sample is taken one after of taking 75 gram glucose, and third sample is taken 2 hours after taking 75 gram glucose. If fasting blood sugar is 5.1 or above 5.1. 1 hour after taking 75 gram glucose is 10 or above 10 millimole per liter, and 2 hour after that sugar after taking 75 gram glucose is 8.5 millimole per liter or above, then the patient has GD. If any of this glucose level is met or exceeded, then the patient has GD. This is not WHO criteria, this is IDPHD criteria, and which is mostly followed all over the world.